Hi, my name is Stuart Sherman. I'm Professor of Medicine and Radiology at the Indiana University School of Medicine and the Glen A. Lehman Professor of Gastroenterology. It is a great honor for me to interview my mentor, Dr. Glen Lehman, for the VideoGIE Meet the Masters of Endoscopy series. Dr. Lehman is a true giant and a visionary in gastrointestinal endoscopy. He has helped shape the career of many gastroenterologists throughout the world. I have had the great fortune to have been mentored by Dr. Lehman. He strongly influenced and helped guide my career. I owe much of my professional success to his inspiration, his guidance, his teaching, his support, and his friendship. Glen, it's an honor for me to interview you. Let's start early in your career. Growing up on a farm, what were the lessons that you learned which helped you become the person you are today?
Well, biased as I am, I think a farm is a great place to grow up. You're out in nature every day. You see the value of hard work and the productivity from hard work. You're a little bit away from big city problems, and it's just a good place to grow up.
Who are your role models growing up?
I would say it would be mostly my parents and siblings. My father had an 8th grade education, yet he put 6 kids through college, and half of my brothers and sisters are teachers, so they were role models for me and when I first headed toward teaching.
That leads into my next question. You started your college career at Ball State University in Muncie, Indiana. What were your initial plans for your career at that time when you started college?
Well, at that point, Ball State was called Ball State Teachers College, and so I was headed toward biology teaching and following the family tradition.
So speak about the motivations in Ball State that led you to choose a career in medicine then.
Well, it was fairly evident in my initial classes that the brightest kids were all in pre-med or dental, and so I sort of liked that association, and I snuggled in with them as pre-med.
So you left the family tree a little bit from teaching to consider a career in medicine at that point.
Yes, no medical people in my family.
So you transferred to IU, and then you went to school at Indiana University School of Medicine and graduated in 1968. You then left Indiana University to go to Duke, followed by your return to IU to do your residency. Who were the people in your training at that point who impacted your career and helped you to make a decision to pursue a career in GI?
Well, at Duke, I had some very favorable rotations on the gastroenterology service. Mike McLeod and Julian Ruffin were a couple of the senior gastroenterologists that were influential. And then back here at IU, our leader was Philip Christensen, and was again very helpful in promoting endoscopy thinking.
So you became a GI fellow in the early 1970s. What was it like back then to be a GI fellow? What kind of things did you do then that differ from what you do now?
Well, it was a different era. That's again 45 years ago. Radiology and barium studies were the diagnostic tests of the day. Endoscopic tools were just barely beginning. Rigid sigmoidoscopy still played an important role. And on a busy day, we would have 3 upper endoscopies. So it was just a different world.
I understand. It's a lot different. So then you spent a few years in the military at Brooke Army Medical Center in San Antonio in the early 1970s. What techniques and lessons did you learn there that impacted your career that was to come?
Well, that interval was a good one for me. It was like an extended fellowship, and there I had the chance to begin ERCP, had the opportunity to visit Otto Nebel, one of the first people who did ERCP manometry, and overall it was just a good learning experience.
Very interesting. So you then returned to Indiana University Medical Center in 1974 and joined our GI faculty. Why at that point did you choose to pursue a career in academic medicine? What was it about it that led you to go that route rather than a private practice route, for example?
Well, the small teaching group here at Indiana University was good, especially with Philip Christensen. Again, keeping with the family tradition, I was interested in teaching, and so that was just a natural to start out in academic medicine.
Understood. So Glenn, who were your mentors during your early period as a junior faculty, and who helped to define your ultimate career path that led you to where you are today? Was it Dr. Christensen?
Since endoscopy was just developing, and therapeutic endoscopy was just developing, I really had no or limited mentors in those fields. On the other hand, Christensen and Jim Meadows provided a very good open atmosphere to develop whatever seemed appropriate.
So did you go to places to educate yourself, or how you said you visited Otto Nebel when you were in the military? Did you just sort of learn on your own at that point?
Well, unfortunately, a lot of this was on our own because there weren't that many leaders around the world. But I did have the opportunity to visit with Joe Geenan for a few days, and of course kept up with the literature and the national meetings.
So that gets into the point you said you learned a little bit about ERCP in the military. You went to visit Otto Nebel, came back to IU, and obviously a lot of your career was spent in ERCP and pancreaticobiliary diseases. How did you really learn to master these techniques, and how did you teach others? The capabilities of teaching back then are not the same with video endoscopy that we have now compared to fiber optic endoscopy way back in the 70s and 80s. How were you able to learn the technique, train the nurses, train fellows to also become expert in that technique in that era?
Well, it was a little bit of trial and error, and proceeding cautiously with new techniques that were not done many times before. That's just part of learning a new technique when there aren't mentors to help.
Yeah, it's hard to get away with that these days, huh?
Well, fortunately, therapeutic endoscopy is a much more mature technique than it was back in those days. So now there are mentors, videotapes, educational materials that make learning much more controlled.
Certainly agree with that. While most people know you for your work in ERCP and pancreaticobiliary disease, many don't know about your seminal work that you did in the esophagus in the mid-1980s. Can you talk a little bit about that and your interest in esophageal disease and what you've done there?
Well, my contention has been that with therapeutic endoscopy, we look at a problem, a colon polyp, a GI bleeder, and we treat it, we fix it. For GERD, we looked at the problem, we quantitated it, but we didn't fix it. And so the thought was, what can we do for GERD to improve it endoscopically? And that came down to injecting something to bulk up the sphincter, sew the sphincter closed somewhat, staple the sphincter closed, and we're just now seeing some of the fruits of that research here in the last decade. But it was a challenging area. It's still one that needs more detail, but I think we made a good first step.
You were the first one to implant collagen in the lower esophageal sphincter, weren't you?
I think so.
Okay, very good. Obviously, most of your career has been made in ERCP and pancreaticobiliary diseases, as we talked about. Talk about the advances in ERCP that you've seen in the more than 40 years that you've been doing it, and how these advances have helped improve patient care.
Well, the advances have been in really all aspects of ERCP, from the scopes, the accessories, the quality of the teams that have developed, all have gone together to make ERCP more facile, more safe, more successful. It's just part of the maturation of the field.
It's certainly easier to teach now with video endoscopy. I think that was probably one of the biggest developments in training. Do you agree with that?
Yes, I would agree. Passing that teaching head back eyeball to eyeball was useful but limited.
Most people don't know what you're talking about, but that was in the fiber optic days where there was an attachment to the fiber optic scope, and the trainee, I used to see some of these people, they would, the staff would be moving back and forth, and the attachment would be moving back and forth, and usually the trainee would get a black eye from being hit by that attachment. You've always emphasized the importance of team play rather than individual success, and I think that's the thing that I admire you most about. And can you speak specifically as to how team play helped elevate IU's endoscopy program onto the national stage?
Well, my contention is a person is as good as his team, and one of the real assets has been that our team has been made up of a lot of very bright individuals from good institutions, but they work together as a team. And when you have a problem, the team can help solve. When you're writing a paper, the team members rise up as the first authors. So team play I think is critical to group performance.
I would certainly emphasize that point. Even an expert like Dr. Lehman usually asks the team when we're doing an ERCP what we think the best approach to this patient would be. Might show us an ERCP image and ask us what we would think the diagnosis is and what the challenges are and how we should move forward in the treatment of that particular patient. So I think all our aspects at IU are team play driven by Dr. Lehman's major focus. We do research together, clinical work together, and we share experiences together. So it's been a great experience for all of us. Now, during your career, you have mentored thousands of medical students, residents, GI fellows, advanced endoscopy fellows, and junior faculty. You've positively impacted the career of many of these people and helped to develop many of the national known authorities in GI disease. What do you feel are the characteristics of a good mentor, and why has this been so important in your career to be a mentor?
Well, I'm not sure I can answer that question very well. A mentor instills interest, confidence, enthusiasm in the topic at hand. The mentor can help the trainee become a leader, an independent thinker. But a lot of that's osmosis, friendship, and I think not well defined where I can say 1, 2, 3, this is how to do it. It's sort of how it's evolved over the years.
Do you feel that a mentor is necessary to be successful? Does everybody need to identify a mentor in order to move up the chain, or does that just quicken the pathway?
Well, it certainly helps, and as I look at your career versus mine, I took a lot more years to develop expertise because of limited mentors. So I think they're very helpful, but not critical in development.
Well, let's turn to a little discussion about the ASGE and your work there. You've had many roles in the ASGE, from a committee member, committee chair, you were a member of the governing board, associate editor for GI endoscopy, to name just a few. Please speak to what the ASGE has meant to you personally and professionally.
Well, I have really been in pro ASGE and tried to emphasize publication in their journal, be involved with their committees, and so on. I think they're the leader group in endoscopy, and it was just the right place to put one's interest and efforts. It's been a pleasure and a privilege to be involved with the bright people of the society and to travel worldwide, partly under their guidance, and meet other bright people and leaders. So it's just been a good group to be involved with.
So one of your major career events was receiving the Rudolf Schindler Award from the ASGE, the highest award that the ASGE gives to people, in 1996. What did that mean to you in terms of what you had accomplished up to that point in your career?
Well, I think it's human nature to want to be accepted by one's peers and recognized by one's peers as doing a good job. And so I took that as an example that somebody thought you was doing a good job, and therefore a nice award. Again,
I remember when you got the award, you shared it with many of your trainees, and again, it was about team play rather than your individual success. You felt that you got the award because of all the rest of our accomplishments as a team. So appreciate that.
Well, it certainly would not have been possible without a home team.
Let's move a little bit to a discussion of research. You've made that a significant part of your career. You've been a prolific researcher during your career, having been the principal author, senior author, or co-author of more than 400 peer-reviewed papers, 75 book chapters, and 600 abstracts. Many of your studies have had a major impact on patient care. Please tell us why research has been important to you and why that's been a major focus in your career.
Well, I think we all face challenging clinical problems every day. And it's a rare patient that comes through the door that we say we know exactly how to manage this problem. There are always uncertain factors in disease management, medication, techniques that we don't know what's the best approach. And so research allows us to address these questions and hopefully come up with answers that will ultimately let us take better care of the patient. So it's just part of better patient care to address the research questions that the patient presents.
I remember early in my career what you told me. You said you needed to be in the trenches to learn to know what kind of questions to ask, and that really has been borne true in my career. You just have to see what the problems are and what's needed to address those problems.
I agree.
You've prided yourself in being a great clinician, providing the best care for patients possible. And you've been considered around the state of Indiana to be the doctor's doctor. Please tell us how young doctors, what they need to do to provide high quality patient care.
Well, that's a difficult question, but when facing a challenge, everyone wants to know the answer to what to do next, how to take better care of the patient. And that comes from research, which then helps find the answer to the next drug, the next technique, the next scope, and so on. So, and then people want to know the answer to that question. I want to know the answer to that question, but every practicing clinician wants to know the answer to that question. So then they invite you to around the world to give the answer to that question. So it's part of finding the right answer and then helping to spread that education.
What contributions to gastroenterology and endoscopy have you been most proud of during your career?
Well, from a patient care standpoint, just good endoscopic technique as it applies to the patient's problem. But from a research standpoint, I would say our work to help make endoscopy, ERCP especially, safer. We've shown that ERCP, post-ERCP pancreatitis can be prevented now with NSAIDs, and we studied a variety of other drugs before we found that NSAIDs were our best step. We've shown that pancreatic stents help make ERCP safer. Your aspirating catheter has made manometry safer. We've shown that in pancreatography, less is better. Less filling is less irritation. So all these safety maneuvers, I think, are what I'm most proud of.
Well, I think one of the things that you, again, are a little humble about is the people that you have trained who have assumed leadership positions in many institutions throughout the world. And I think, to me, having been one of your trainees, that's what I'm most proud about you, what you have accomplished.
Well, I didn't mean to leave that aspect out, but I totally agree.
What advice do you have for future generations of GI trainees who want to pursue a career in GI focusing on therapeutic endoscopy?
Well, the first step, I think, is find a good institution that lets you develop, find good colleagues, find bright colleagues that lift you up, and then you ride with them to success. Keep score, have a database that keeps score of what you're doing, so that 5 years from now, 10 years from now, you can say, well, we had 450 of this or that, and that's then retrospective research. And then I think I said, surround yourself with bright people. You're as good as your partners. You need a good team.
And mentoring would be up there if possible, correct?
Sure.
Glen, you've accomplished so much during your career. You've been a role model to many of us. What's next for you?
Well, I'm getting old and a little shaky, but I would hope to still play a role in some aspects of research or teaching, and I do want to catch a few more fish with my fly fishing. So.
And we'll give you that time.
So a combination of still working some and a little more family time and recreation time. And with that, I'd have to thank my wife, who's put up with sometimes a schedule that was a little too busy, but she's been a support throughout all this.
Any final words? Words of wisdom?
Well, again, you're as good as your team, and I couldn't be more proud of you as your accomplishments and as a team player.
Thank you so much.
While we were videotaping, this is the team that was working and taking care of patients. We'd like to get them on camera and introduce them. Jeff Easler, Evan Fogel, John DeWitt, Mo Al-Haddad, and our newest member, Ben Bick, Jim Watkins, Lois Buxott. Lois has been in GI for 42 years. That's as long as me. And so we're a vital member of the team. Thanks.